This talk is on exfoliation syndrome or pseudoexfoliation syndrome. This is the most common secondary glaucoma. It's extremely common, especially in the elderly and in some populations, and can be bilateral or unilateral. By far, it's the most common cause of unilateral glaucoma in the elderly. The naming of this drives me somewhat crazy. It's also called pseudoexfoliation, so it depends a lot on which work you look at, and I have changed the name over and over in my own publications. The lens changes that we see resemble those seen in the splitting of the anterior capsule that was caused by intense infrared energy, and this was called exfoliation of the lens capsule, and it was seen in industries with high heat, such as manufacturing of steel and glass. We really don't see it anymore because worker safety laws protect against this type of exposure. So this is true exfoliation. This is somebody with industrial exposure has splitting of the anterior capsule. I will call the disease exfoliation syndrome. Most of the references that I've looked at use that term, but recall that that is synonymous with pseudoexfoliation syndrome and pseudoexfoliation glaucoma. Confusing, I know. What we see is fibrillar material that's deposited throughout the anterior segment of the eye on all structures bathed by aqueous. It's interestingly been found in other organs throughout the body. Virtually anywhere that people have looked, they found this material, the lung, the liver, kidney, etc. And there are papers that describe all manner of relationships with systemic diseases, including dementia and hearing loss. But in two very large studies, including one recent study looking at mortality from all causes in people with exfoliation syndrome versus age-matched controls, there really is no increased mortality. So while there may be some disease associations, I wouldn't try to remember them. I think these patients live normal lives. They may be at some increased risk for some diseases, but it doesn't cause them on average to die younger. This material is made at all levels throughout the anterior segment and also in the optic nerve. It's made in the corneal endothelium, the trabecular meshwork, all layers of the iris, equatorial lens epithelium, ciliary body. The genetics, I think, are important. The LOXL1 gene, lysyl oxidase-like 1 protein, was discovered in 2007 in a large genome-wide association study that was done in Scandinavia. And what this study found was that those who have the highest risk alleles are at 700 times the risk of developing exfoliation glaucoma versus those with the lowest risk alleles. But the majority of the population who have high-risk alleles never develop exfoliation syndrome. So it increases the risk, but is not a disease-causing gene. And measuring for LOXL1, at least currently, is not really very helpful. This is a disease of the elderly. It's rare under age 50. These patients are even older than primary open-angle glaucoma patients. There's no sex predilection. It's seen almost everywhere, but clusters geographically. And there is some new evidence that it may have to do with sun exposure and the angle at which the sunlight strikes the eye. But there are places where there's just lots and lots. Scandinavia, for example, has a lot of exfoliation. Like primary open-angle glaucoma, there are no symptoms until vision loss occurs late in the disease. What do we see on the exam? You can occasionally see exfoliated material clumped on the endothelium. It looks a little bit like a ceratic precipitate, but sometimes these will actually wave a little bit in the aqueous. In the trabecular meshwork, you get this brown sugar change. So different than pigmentary glaucoma, where the pigment is really, really black. This is an admixture of pigment epithelium from the iris pigment epithelium with this white fibrillar material that gives it this brown sugary look. You can see a Sample-Lacey line, which is a deposition of pigment anterior to Schwalbe's line. And this is just another Lee Allen painting just showing this brown sugar pigment in the angle. This is someone who actually has a clump where you can see that a piece of the white fibrillar material from the lens has fallen off into the angle. And just a video showing the iridocorneal angle in somebody with exfoliation syndrome. You can see the Sample-Lacey line up here. And if you really pay attention and look inside the pupil, you'll see frosting on the zonules. A little bit pixelated here at low light. I think I'll open up the beam here any second and you'll be able to see that more. There we go. So you can see this frosted zonules here. One can see exfoliative material at the pupillary margin and transillumination at the pupillary margin, because this is where the pigment epithelium is rubbing against that granular material that's on the lens capsule, which we'll see here in a second. On histopathology, there's a sawtooth degeneration of the retinal pigment epithelium that on transillumination, sometimes you can see these circumferential rings, like the rings of a tree. The iris becomes rigid, it dilates poorly. This is a woman who has exfoliation syndrome in her left eye, and you can see that that left eye does not dilate. One of the reasons that cataract surgery is not very pleasant to do in these eyes. And this is somebody, it's not a great picture, but it's capturing someone who's dilating, and you can actually see this pigment coming from the pupil lens interface and just being released because of the dilation. It's important, people with glaucoma, to study the lens after dilation. You'll see fibrillar material on the lens capsules. Even in patients who are unilateral, there's ultrastructural evidence of exfoliative material on the contralateral lens capsule, and you may later see those patients developing exfoliation in that eye. You have this ground glass frosting on the lens capsule. You can see here it's actually scrolled up from the movement of the iris. And where the iris has rubbed back and forth, you get this area that's cleaned off and leaves behind the exfoliative material in the pupillary space and in the periphery, giving this bullseye pattern. You can see exfoliation on the zonules, and this weakens the anchoring sites and weakens the zonule itself. This is a subtle video, but this is somebody who has phacodenesis. So every time he looks around, you can see the lens shaking just a little bit. Really important to look at these people before you get them in the operating room, because you'd like to know that lens is not very stable. This is a really old video, so it's not great quality, but this is a woman who presented with spontaneous dislocation of her lens from exfoliation, and you can just see her zonules wafting in the breeze there. This is someone with a dislocated intraocular lens and sort of a time lapse of a lens drifting into the vitreous here over the course of 3 years. There's exfoliative debris on the ciliary body, as you can see in this histopath picture here that Doug Cameron gave me, and you can also see it on the face of the ciliary body in a dilated exam. with the gonio lens. There's electron microscopic evidence of exfoliative material in optic nerve heads. They have elastosis that is not seen in normal controls or even people with primary open-angle glaucoma, that suggest abnormal synthesis or degradation of elastin in exfoliation syndrome. It's an important and independent risk factor for conversion from ocular hypertension to glaucoma in several studies. So even at low pressures, exfoliation syndrome can place people at increased risk for developing damage. In the early manifest glaucoma trial, the conversion from ocular hypertension to glaucoma was twice as high in exfoliation syndrome eyes when compared to non-exfoliation syndrome eyes, when controlled for pressure, age, and gender. So this is a typical exfoliation patient with unilateral glaucoma. You can see their OCT here with marked thinning on the right and severe field loss on the right. We treat it like primary open-angle glaucoma, same medications, trabeculoplasty, surgeries. Trabeculoplasty may be more effective than in primary open-angle glaucoma because of the marked angle pigmentation. The zonular weakness and the poorly dilating pupil make cataract surgery challenging. I think most people now prefer to remove the lens fairly early in the development of the cataract while the nucleus is not rock hard and while there's still some zonular integrity. Capsular tensioning rings can be used if there are areas of weak zonules. Remember that removing the lens does not stop the exfoliative process. These people can have a much more abrupt pressure course than primary open-angle glaucoma patients. So when you see a primary open-angle glaucoma patient back, the pressure might gradually increase, but in exfoliation patients there can be a striking increase between visits. And with the zonular weakness, the lens can move forward and cause angle closure. So these patients deserve periodic gonioscopy. So the main points in exfoliation syndrome: leading cause of unilateral glaucoma, particularly in the elderly, most common secondary glaucoma, associated with the LOXL1 gene, has a more aggressive course than primary open-angle glaucoma, and is an independent risk factor for optic nerve head damage. And cataract surgery is very challenging. It's something that probably should be done early in the course of the disease. So exfoliation syndrome is something you'll see a lot of almost anywhere you live, and it can be a very challenging disease to take care of.